Now we move on to our next session. That is roadblocks and challenges what we are facing nowadays. I request the chairperson T.B. Lahane sir, Dr. Jagat Ram sir. We have panelists Dr. Kirti Singh madam. So I request panelists to be on the front row. Yeah, Vijay Pai madam is there. Welcome madam, greetings from Karnataka. Dr. Modni Pandapurkar, Dr. Girish Rao, Dr. Mohan Rajan sir, Ravindran sir, Dr. Rahul Deshpande. So this session is basically going to be an interactive session. We had about 30 people, 30 teachers who had registered for this today's course. Sir, one more chair. You are a panelist. You can pull 5 people in the front row. Kirti ma'am. नहीं रुकेगा because we won't be able to conduct the we need discussion. Sir, we need you. Yeah. So basically the theme is here we had about 28 people who had registered for this particular. They are teachers from various colleges across the country. So we have asked 8 people to represent them. We have taken a pre-recorded videos from them about the challenges which they see in their own systems of their in the place of work. So we'll be sharing with you those pre-recorded videos, and then we will initiate for half an hour a detailed discussion, because all the elite people who are in the front row as a panelists as well as chairpersons over there are the most prominent teachers of our country. So we'll try to seek solutions from the problems which have been put across, and any other problems which come across during the discussion will be further. So it's a 1-hour program. I request panelists whether you want to discuss all at once, the 30 minutes discussion, or do you want the discussion after each video presentation for 2 to 3 minutes?
I think the total presentation at the end of session, that would be better. But I think at the end of each video may be better to address that.
Okay, we'll do it like that. We will see how it proceeds. Okay, yeah. There is a possibility that we might forget what was the video. So we'll have 2 minutes quick brisk answers from that. Okay. We will conduct a moderated from that. Go ahead. Okay. So this is the first video. Come.
We have no hopes of seeing our college campus before we graduate.
This is from Professor Arvind Maurya, who is a professor at AIOS Yeah.
Said an ex-third year MBBS student from a Y, All India Institute of Medical Sciences, that is still under construction, glaring from one of the makeshift classrooms. Well, it's a common scenario at all newer AIMS. Myself, Arvind Maurya from AIMS Hyderabad, and I will be sharing my real-world experiences on the roadblocks in delivering ophthalmic education at such neoteric institutes. Most of the student, resident, and faculty joins AIMS with a hope to experience state-of-the-art infrastructures and advanced facilities for the education and research. But the truth is bitter, as there is very little provision and framework available to attain excellence. On demanding, we only get starry pitari and nothing else. Faculty always wish for the best cutting-edge equipment, but gets lower-end and outdated machines. Also, there are unrealistic expectations from the management to overperform with the bare minimum armamentarium. Patient wants all procedures under the same roof, and residents expect abundant clinical and surgical exposure by working from 9 to 5 p.m. and availing maximum leaves. So, either we could crib and cry or flow like water and make our way forward. By following this simple principle, we had pulled off a miracle by developing a high-tech OPD and separate ophthalmic OT, running 53 projects, including 11 RCTs, extramural Government of India projects, initiation of UG, PG, MD course, and among the fewer aims to commence BSc honors course in optometry. I believe that everything is possible. Thank you so very much.
We have 3 minutes. We open for the discussion.
Can I
Request? Yeah.
It's a very common scenario in even Tamil Nadu. Every district has got a medical college. Only the building is there. faculty, nothing is there. So the aim is to start more medical colleges, but the problem is the faculty is not available. That is the biggest problem. And at least in AIMS Hyderabad you got a building. In AIMS Madurai, only one stone is there. Only one stone.
The story I was telling, the first slide, that was from the student, MBBS student from Madurai itself.
AIMS Madurai only one stone, and
Yeah, I know.
Nadia knows about it very well because he knows that. So that is the biggest problem we are having. So, but you have overcome all the odds and you have done it so very well. That requires a lot of self-motivation. But very few people in the faculty level like you have the self-motivation to do it. Because if we don't get anything.
Learning from senior like you.
No.
I think Kirti madam is in a government setup. She can represent and speak how the liver faculty should cope up with these challenges which they
You know, more than what the AIMS, like see, AIMS always has been the blue-eyed baby of the government, whichever government it is, okay, whether state or central. Now, there are many medical colleges which have come up in district hospitals, and they are giving MS degrees or MA degrees. It is literally a PHC where the people did not have any experience, but suddenly have been put into cold water that you start teaching. They are either doing private practice. That's a harsh reality. I've done inspections in those colleges. So the building is there, the stones are there, the blocks are there, the OT is there, everything is there. But and the faculty also so-called are there. But they don't have the experience.
Skill.
They don't have the skill. They don't have the initiative or the patients actually. There are very few patients, but now they've given designation of that. So that is the harsh reality that many medical colleges are there only on paper. Okay. Now, even if you get a faculty like we call him catalyst, many people call him that. So a fire person like that, what will they do if they don't have the stuff? So AIMS is actually, you cannot extrapolate it to all over India. Having said that, for ophthalmology, it may not be true for the other specialty. For our specialty, there are institutes of excellence like Aravind, LVPI, Shankara, and even the other Shankara hospital come up, which are giving a state of art. So, government institutions now are, this is a fact, they're not rated that highly as it was in our times. You know, we would go for that. Other than the paying capacity of the students, because patients are also there, and very rightly said in the last session, because of Ayushman Bharat coming in, many good government hospitals don't have patients. So our forte was patients, and if the patient's forte is gone, then really, so that is the reality which if AIOS-ARC come into it, and if they advise in the planning that when you set up a new college, it is just not enough to have a stone or the building. It is important to have the requisite faculty. Last but not the least, the faculty which is being
Trained faculty.
so you can't have an on-the-spot training. It takes time. So the payment given to them is pathetic. Like my hospital, Guru Nanak Eye Center, ad hoc faculty is given 1,10,000, and
It's less than a senior resident.
they would get thrice as more if they go into practice. So really, it's very few passionate teachers, or unfortunately, I'm a lady, having said that, ladies who just want to take care of kids and the husband says ki thoda kaam kar lo. That is a true reality. They are coming in as teachers in these institutions because the payment is very abysmal. So we need to think of the long-term future by redressing these. These are the problems I have seen.
I think we have Dr. Lahane sir, who had been a DM here, who was into planning, and also we have Jagat Ram sir, who was the director of NMC and all.
I was
So what do
DM.
you people feel when you
I was the
envision this?
director of medical education for 4 years. What I want to tell you is, what you said is very true. About the payment and about everything, it is very true. But when government take a policy decision, in that they think of the, you can say, public at large. It means you see the doctor and patient ratio in India is very, it means doctors you can see for more than, you can say it is only one doctor for the more than 1,000 people. So that is the ratio. And whenever we are considering that we are developing in India, we will have to increase the number. Secondly, what happens if the planner is good? When I was a director, I told them, I put my foot down, that yes, we want the pay we want that if a person want to go to that hospital, then the Maharashtra Public Service Commission should advertise that in the Nandurbar, we have the medical college, you want to join there or not. It means our MPSC will be advertised in the post according to the medical colleges. It is not that people will be transferred like that. It is possible to do it. Secondly, about the training of the doctors. See, at the beginning, nobody is trained. So gradually they will get trained. About the pay, I do agree. The pay is very less in the government. But in that pay also, now what we are planning there is, yes, we are allowing the private practice so that they can do practice after the 5 p.m. and they can earn from that. But basically, we'll have to think of the doctors, but same time we'll have to think of the government. And in that government, we'll have to think that how we can provide more doctors. And those, I will tell you, in Maharashtra, 3,000 doctors are not there in PSC. Why? Because the number of the MBBS doctor is very less. If the posts are advertised, I will tell you, the only 800 posts are advertised and the applications were 10,000. Now, as a director, what I can do? Then I will have to conduct the examination. So there are so many problems are there, and so we'll have to solve those problems gradually. So I think whatever is there, so we should, as an association, should be able to bail the government that this is the requirement of ophthalmologist or ophthalmology department. And for that, advocacy is very important, that our people, our association, lying in Mumbai, in Maharashtra, I am telling the government, this can't happen. I am just advising the government, no, this can't happen. You can't do that, even in the Doctor Protection Act or even in the any other policies. So there should be advocacy properly, and if it is there, then it is possible. So it should happen at the higher level, what I feel.
Very valid point, sir. Last comment from Jagat Ram sir, and then we'll move on to the next.
I also agree with Dr. Lahane. Actually, there are not uniform criteria between even government. There are AIMS New Delhi, PGI, Pondicherry. They are not under MCI. Even if while I was a director as well as a member of the NMC or initially MCI, 50% of the new AIMS, they were not having even 50% of the faculty. Even then, their recognition was not under MCI. But in the other places, what happens that there may be 70% or 80% faculty, they were not recognized because medical college, other private and other, because it was not, it was under NMC or MCI. So criteria are also different. So there is a truly problem of teachers. And students are adequate. I think number of students everywhere, there are lot of number of students.
Thank you, sir. Just one point which Kirti madam made is now the Ayushman Bharat, all the cases are being taken away by the private and not by the
We have
government.
no hopes of seeing our
That's absolutely the reverse way in Karnataka. Now they have started what is called as ABARK, Ayushman Bharat Arogya Karnataka, where no private hospital or anybody can do a cataract surgery. It's only when they are referred through the government hospital that facility is not there, so you please do it. Then only we are able to do it. So for that, I think you need to have a different governments in the center and the state, so that you will start getting more same government in that, then it won't be possible. Okay. Can we move on to the next one?
work available to attain existing and outdated machines. Patient wants all. We have faculty of.
So Dr. Mukesh Kumar is from a
Hello,
consultant at
I have two suggestions for the betterment of the education program for the postgraduate students.
they have DNB
And
course
the
in
same
this.
suggestion are applicable for the students who are doing fellowship after completing their post-graduation in the field of ophthalmology. The first suggestion, it's better if we start teaching journals, various journals along with the textbook in their classes. This helps them to understand the latest trend in the field of ophthalmology, at the same time they will understand the latest treatment protocol. So I am in favor of textbooks which are available, and at the same time I want to add various journals, various publications for their teaching program during the post-graduation. Second very important point which I like to add in their teaching program is the clinical based, diagnostic based, OPD based case discussion. I have an example. If you want to differentiate between the angle-closure glaucoma case and the open-angle glaucoma case, you need to learn the gonioscopy examination first. The same, to understand the squint examination, you need to learn how to measure deviation. So this clinical based understanding of their case will help them to become a good doctor in the field of ophthalmology. My third suggestion, we need to add the subspecialty based classes and the case discussion for the postgraduate students. What we notice that there is a common classes for all the students, and at the same time there is a common teacher. So suppose if there is 4 or 5 faculty in a department, why not to distribute the topics to all the faculty? One will help them in the glaucoma, one will help them in the retina. And if we start this subspecialty based teaching program, definitely all the teachers will focus on the one specialty, and they will tell them, they will try to help them, they will clear their concept in different subspecialties. It is not possible for one single teacher to teach all the program, to all the courses, to all the chapters in the field of ophthalmology. So this subspecialty based teaching program is very, very important. So these are the few suggestions which I like to highlight, I like to share with all of you. Thank you very much.
Thank you. I think I will now take inputs from Vijaya Pai madam.
I think as per NMC, as per NMC, each department is supposed to run specialty clinics. So, every medical college is supposed to have a specialty clinic. So, PGs by rotation, they get posted there and they do get exposed to these specialty clinics. So, I think running the specialty clinics in the department helps to take care of this subspecialty training.
But the challenge in majority colleges do not have. So, what is the solution you would like to offer to people who are seated from a government colleges across behind as a
even many of the government colleges do have people who have trained in certain specialties, and they do run the specialty clinic.
Okay.
I just want to ask the panelists, is it a leader based always that the HOD has to direct it, and then that the teaching has to be the subspecialty that you take retina, you take uvea, you take oculoplasty? Because in most of the colleges where I see is the subspecialties have still not developed in most of the medical colleges.
You are very correct. The problem is, as we are speaking about the NMC. NMC writes that there should be specialty clinics in the department. But NMC also says that for the department, requirement of the staff is only 3. 1 professor, 1 associate professor, 1 lecturer. How it is possible? That is irony. It is not possible that they can do like this. So, as a director from the government of Maharashtra, I have written to the NMC that your circular says that I should have a 6th specialty in the ophthalmology, like other subject also. And you are asking me to have only 3 people to be employed. Why not 7? Why not 7? So unless and until you increase the number, you want a number patient also, you want specialty also. And if one person who is a HOD and is saying tum retina padhao, tum ye padhao, those days has gone. Now those days are not there. The days are of specialty days. And for that now we have to change in NMC so that we can change in the medical colleges.
Sir.
In Aravind, we are also moving towards a flipped classroom. So wherein we give the access to a lecture by a particular doctor from the organization. So they are able to listen to the lecture. They are able to go through all the related material about 2 weeks or even 3 weeks ahead. And then there are a group of residents who put together some MCQs. And the whole classes, they should have read it. When they come, there are about 40 to 50 MCQs are there which they have to answer. So, and they are also able to answer, and we are able to take a poll, which is the correct answer, and then we are also able to clarify that we are able to make sure that they have read, they come prepared, and we are also able to have individual scores, which then we can go back to that resident who has scored less to understand why they are not able to understand. And usually the role of faculty is to be a facilitator, to explain why something is not correct. So, I mean, we are trying to see how the residents can take the responsibility even for the teaching, especially when they are the second year or the third year postgraduates.
Dr. Soni, you wanted to say something?
Madam wanted to say something.
Actually, in our institution, we do have the residents presenting and the faculty sitting at the back. Fortunately, we do have faculty, 6 faculty taking charge of 6 different super specialties. We do run specialty clinics. But I have also worked in the State Medical College with limited faculty, where these clinics were just not possible. At the same time, what we were doing there as teachers to encourage our students in specialty training was to direct them towards, even in my video you'll see a little bit of it, that to direct them towards resources, learning resources of super specialty if the individual specialty teachers were not there.
Can I take this opportunity to request people from Center of Excellence like Dr. Ravindran, Kirti ma'am, they have all the subspecialties in their places. Why can't we, the participants in the peripheral colleges, borrow the postgraduate teaching programs online or something like this, which you can share? I'm speaking on their behalf to people like you, sir.
So, we don't have the same capacity in all our hospitals, which we run PG program. So, some of our hospitals where the specialty is not well developed, those postgraduates attend online classes. So, we pair between the institutions.
So, we are asking you to grow
No,
beyond
we can do it for others.
To that so that
we are open to sharing with others.
Yeah.
So, we are open to sharing with others. Yeah.
Yes, ma'am. So I think this is a good opportunity people can align, and the crib that this particular subspecialty was not taught in our colleges because of want of faculties. If we have today is an online world where if the people from Arvind, SM, MMC, RPC, we can take this opportunity to request them and get these programs.
I'll answer your question first, and then I have 2 suggestions. The first question was, why can't we do it? We've already done it. COVID time, when that scene was shot, we started Guru Nanak, I said it. It's something called a Sapere Audi, which I started. It's in Latin that it means you dare. And we had 100 registrations. We got a Zoom platform and we did that. And surprisingly, we had only limitation of 100. It was all over the country because COVID made no teachers were willing to take because they were all busy in fighting COVID. And I'll just share one anecdote. I went to Chitrakoot Hospital around 6 months ago, and one gentleman who was moderating the session came to me and touched my feet. I said, "Oh, I don't know you." He says, "Ma'am, because of your superiority, I could clear the exam because that classes were useful." So it has a big platform. The only problem which I foresee in this is COVID was a force majeure. Okay, we could do things. To take government permissions is that only Dr. Lahane and probably sir can do it. It's not easy for every medical college to take government permissions because for teaching platform, we can do it if AIOS takes a lead and every states are allowed. We would be happy to do it. Second, the problem which I find in this specialty, the sirs very rightly said that 3 people are there and you expect 7. मतलब जादू कैसे हो जाएगा? And what I feel is lacking is, even at AIOS level, you are all the AIS maestros sitting here, the focus has to shift from cataract to the other specialities, which is there, including life surgeries. It may not pay, but if you really want to do that. Second, the focus has shifted, like DOS has done it, Delhi Ophthalmic Society, skill training labs, which even you guys are, us, we are doing it, it's not you, it's all us. That is the skill training, like gonioscopy was talked about. We have the squint, gonioscopy, retina, IO, and all those skill training sessions because residents very rightly said by the gentleman that they don't know how to do it because they don't see it. So instead of just didactic lectures, we have the skill transfer lectures, and Prayogshala by AIOS is a very good initiative in that. We just took part in it in last month, and it was really, really good. So the state societies and AIOS has to step in into this from the point of view of, I'm sure Arvind would be their own, but from the state point of level, Guru Nanak would be very happy to do it if the requisite provisions, we have the capacity. And we have done it as a already, it is a pilot study we've already done. It can be done.
Thank you ma'am. Let's move on to the next video. Sound?
Yes, please.
As we have no hope.
So these are
and the number
which I like to highlight.
training the trainers, roadblocks and challenges. And for the solutions, we look to the other participants and also the panelists. So as we all know, according to the new NMC guidelines, the number of hours of lectures have been reduced and the number of hours for small group discussions has been increased. This is of course a welcome change, because in lectures, which are usually large groups, most of the students become bored or become inattentive. But we still do have lectures, and to try to make students more attentive, we used to either try to put MCQs at the end of the lecture in the form of Google Forms, or the teacher can try to walk around the class during the lecture or ask questions to random students in between, or for example in 8Com lectures, which can be slightly more boring, you can do some sort of role play. So I would like to ask everyone else, panelists and the other participants, what other methods can we use in the lecture classes to increase attentiveness? Small group discussions. Of course we need smaller groups, which means that we would require more teachers, senior residents. But as we all know, there is a huge teacher shortage in many medical colleges. The first slot, we direct them how to study about the topic, and second slot is assessment, which we usually do in the form of MCQs. So I would like to ask everyone, what other methods can we use for assessment here? Coming to postgraduates, refraction is something which we tend to ignore, but this is an important aspect according to NMC again. So in our college, in the new roster, we have kept classes by optometrists, and also we encourage students to do refraction on admitted patients. And I would like to ask everyone else, what other methods of teaching can we use to further improve refraction? One other important aspect I would like to ask everyone is how to set up a good skill lab in ophthalmology for both UG and PG students. Coming to the MBBS logbook. So there are so many skills which we have been asked to certify by NMC, as you can see here. One thing which we've done to make it easier for everyone is we have clubbed the competencies according to vision, eyelid related, red eye related, foreign body removal or fundus examination or cataract related. The PG logbook, however, needs a lot of improvement. Here we are still using the common logbook which has been given to all postgraduates of the institute. So as you can see here, it still asks about analytical skills and lab reporting. This we are trying to change. List of surgeries, procedures performed independently. Here we have tried to add another column which tells if any complication has occurred and how that complication has been dealt with. Attendance record for seminars, journal clubs is also important, and how the BGs have presented in case presentation, and also seminars and journal clubs. And this of course is for the protocol of the thesis. How far along have they worked on their current thesis? So I'd like to ask everyone, how else can we improve UG and PG logbooks? Bedside teaching. So as NMC has said, that relevance of beds and admissions in ophthalmology has really gone down, as most of the surgical and special investigative procedures are being performed on an outpatient basis. So they've asked that most of the teaching should be imparted in outpatient departments and special clinics. So I would like to ask everyone, what are the teaching methods that can be used in a busy OPD or clinic? Again, another thing which NMC has said is that students should be able to independently perform and deal with complications arising from following surgeries. So in a high surgical load institute, of course, it is easy to give all these cases to PG students, but this is not so in all institutes. So I would like to ask everyone, what are the challenges in implementing this? And are PGs getting enough surgical cases? Thank you. My dear fellow teachers of ophthalmology.
I think there are too many questions in that. So let's try to quickly figure it out, sir. Sir, about the different modalities of teaching, we'll start with Jagatram, sir. Like they said, the role play, the small group discussions, the bedside discussions, the case-based discussion, or interdepartmental kind of meetings, interdepartmental discussions. So just a few.
No, I think whatever said is right. There were a lot of questions and there has to be a lot of answers. But I think we should pay more attention, such as that teacher should ask questions. I think we should give opportunity for the student also to ask questions. It should not be one way. In the beginning of the lecture, it was said. Then what type of teaching? I think ideally, whatever group discussion and other things are fine, but it should be such as practical base. Such as if you want to teach about surgery, if it is a surgical video, that will teach better than if you are theoretically telling just like that. So it should be ideally video based surgical training, part of it. I am not saying whole of it, theory is fine. So that video based teaching is one of the modality. Of course, refraction has to be done practically. Usually it takes time. They should be given time every day or once or twice in a week to do the training of refraction. And then the skill, enhancement of the skill. Skill is first, I think once we do surgical training, first we do wet lab training. Then after the wet lab training, then assisting as I think in the previous lecture, Dr. Ravindran and Dr. Tatiyal also said that go to give step by step. Maybe in the first days this step, then incision, then capsulotomy. I think step based. Not suddenly that overnight a person will be perfect in cataract surgery. So that has to be there.
Thank you, sir. I'll ask specific questions, so we'll stick to that. The next question I would like to ask is Vijaya Madam. She explained about the SDL, that is the self-driven learning. How do you think, how seriously are these students going to implement this, or even if we impose it, how successful are these self-driven learning really is in practical scenario?
We do have, undergraduates tagging the postgraduates. So they do come to the ward and along with the postgraduate, they see the cases, and so that way helps them to how the bedside evaluation is done. So plus we make sure that attendance is compulsory. If not anything, learning is not an incentive, at least attendance works as an incentive.
Next question to Ravindran sir. Sir, when they are talking about the logbook, manually all are writing it, I don't know, they just check it, they just get it. Is there any software based analysis, like for the HR metrics and analysis, Arvind has developed a wonderful software where you know that what is the attendance of each, and so is there any software metrics and analysis that we can follow, because you showed what are the complication rates in the first year, second year of PG students, third year. So is there one software which can analyze the whole postgraduates instead of writing in the logbook?
So, no, fortunately, we have a computerized logbook. It's a software application where a student can log in. No, initially, as soon as they join, all their details are all pulled into that. And for each month of their posting, then there is a list of, for example, somebody is posted retina or glaucoma, then we have a list of cases they should have seen. So they have to write the names of the patients, the MR number of that particular diagnosis they have seen. Then they should have seen certain number of investigations like OCT or fields. They should have observed 5 or 6. They should have done by themselves 5 or 6. Again, like glaucoma, they should have done at least 5 YAG laser iridotomies. They should have watched 5. All of that is documented by the name of the patient, ID of the patient. It's all entered into that. And this also have to be ratified by the HOD of the department. And then it goes to the academic director or the coordinator who will have access to that. And as a batch, we'll also be able to evaluate each department as to, because each one of them has got a score. And each department we can say that you are able to teach the students well. You are not able to do it. You are able to teach the clinical part but not the investigation. So we have a composite software which is available. People, we can give a demonstration online at any time.
Thank you, sir. Last 30 seconds to Kirti madam and Lahane sir, because you both come from a government college background. Now the last question she asked was about the surgical chances to the postgraduates. Now, how is it the real scenario of the surgical chances giving for the postgraduates in the government sector?
Can I take 1 minute and not 30 seconds?
40 seconds, because we are already running late. 40
So
seconds.
for the question which you asked was the surgical, with God's grace we have enough. Our students do at least 100 cases before they move out, including PICUs and SICs. And we have a structuring, the same thing they showed us, that structuring is so easy. We have wet lab, simulator, and in the way, sir also, Arvind, we borrowed from Arvind, we have the AIOS-ARC grading. So AIOS-ARC grading gives you the realization that how much you have learned over the time, and that is the journey of the student herself and how she has improved with the AIOS-ARC grading. And then we have the live surgeries. So we have enough patients, but the idea of going to the camps is also should be explored. The other question which they asked was how to teach in the busy OPD. First of all, I believe again for the senior people sitting, if you have any say in it, people who have DNB or MD or MS, they should have at least some patients who are admitted, even if it is 10, 15. Because it's very easily said कि OPD में पढ़ाते हैं, OPD में बहुत पढ़ाई कई बारी नहीं हो पाती है. But the way to do it is OMP, 1 minute per chapter, and Peyton's 4-step approach for the clinical skills. And these are structured modules, and with that you have a mini CX or a DOPS, which is assessment. So all MEU, sir is an MEU leader, he would know all that the MEU is mandatory in most colleges. So the teachers, if they get this training of how to do the assessment by DOPS or by mini CX, and they give that pro forma to the student, and then they show by Peyton's or by OMP in the OPD or in the OT. It can be both. Surgical skills in the OT and the clinical skills in the OPD or the clinics. It is doable. At the end of the OPD, give 1 hour extra and do this OMP, and it can be very easily done.
I think, yes, what madam said is correct. We should go like that. So,
We'll move on to the next.
yes, next.
So we'll finish 2 to 3 videos and then we can go in for the questions as well. Yamini madam, please come over the dais.
The sort of role play has been during this process. One of the foremost hurdle is a busy schedule with packed and crowded OPD days, solving difficult and crowded OPD here. Again, another ophthalmology. I'm going to talk about my 20 years journey in ophthalmic teaching, the challenges I have faced in delivering knowledge to my students, and few solutions I could find during this process. One of the foremost hurdle is a busy schedule with packed and crowded OPD days, solving difficult cases, doing OPD procedures and minor OT procedures, at the same time trying to teach clinical skills to our postgraduates and undergraduates, and finding time to discuss cases and differential diagnosis. So some solution for these problems are always trying to troubleshoot and encourage the PGs to come up with their own diagnosis and management options, and to keep encouraging them to do the diagnostic techniques themselves and go back and learn and come back, give their answers to your questions, and encourage them to study every day. And on OT days, PGs are always running around shifting cases, giving peribulbar blocks, answering to anesthetist queries, and to involve them in the surgical steps and getting them to assist and learn is a big hurdle. So what the solution I thought was, I always try to share surgical videos and articles on the relevant cases on the pre-op day, and if they come prepared, I reward them with a chance to assist, so that they have an interest to come back and tell you and get to learn some surgical techniques. And the third hurdle and a very large threat to very knowledge among these postgraduates is a instant Google knowledge, which is very shallow and never leads to in-depth acquiring knowledge. So regular short lectures and weekly homework of small topics and a good teacher-student interaction and to guide them through sharing articles, videos and periodic theory and practical exams is a solution I thought of. So during the seminar sessions also, I try to interact with them rather than allowing them to go in the process of presentation in a boring way. So I stop them, ask them questions, involve every PG in this process, and I go and do a blackboard teaching in between the whiteboard teaching also, and ask them questions in between. So during this journey, I have learned to be a learner also.
Shall I continue with that? Okay, thank you.
So Yamini,
Just want to add one thing,
Yeah,
because
please.
I have heard all the previous
please.
previous sessions. See, in some colleges like us, we are
Like
in
St.
the
John's. Like St. John's.
St. John's, we are in the transition where we all have gone through learning comprehensive ophthalmology and we can manage most of the cases. And our junior staff have come with training in subspecialties. So in classes also what happens is, some of us will teach everything, but all the junior colleagues, they know only cornea, only retina. So they sit back in the class and they look at their mobile, they don't involve in the class. So only one or two like us are left, where we know most of, like something of everything. So for example, St. John's is not getting people who are training in subspecialty because there are more lucrative offers outside. So we don't have enough people who can teach subspecialty. So we are trying to rope in and teach. So I think, I don't know where is the solution for all this, but whatever we can, we are trying to do. Because some of us in between, we went and learned some subspecialties, came back and tried. For example, after so many years, I went and learned oculoplasty. So I try to teach oculoplasty to my PGs and give them video. Nowadays, it's very nice actually. All these online classes are really good. So my PGs sometimes go through them and come back and tell me. But I think there is a large gap which still needs to be filled in. I think most of the teachers will agree with me.
There is only one subspecialty which is not being trained by many of the institutions, that is pan-ophthalmology. So I think we can start that pan-ophthalmology subspecialty.
Actually, I also did 1 year course in glaucoma in between. So when I went to LVP, I did my oculoplasty. So the teacher, how much will you do, Yamini? I said, I want to become a specialist in subspecialties. I mean, that's what some of our senior teachers are trying to do. Because we don't get everyone who knows everything. So that's all.
Thank you, madam.
Thank you,
Wonderful
Dr. Yamini.
inputs. Thank you very much. We'll take it at the end.
What we will do is, for want of time, we will just run through because every video is invoking a lot of
Dr.
discussion.
Sarita Agarwal is there?
Yeah.
Yeah. Yes. Please place the video.
Limited hands-on experience. Being a private
Presentation switch कीजिए please.
Presentation and video.
Yeah.
Funny, I have learned to be a learner also.
limited hands-on experience. Being a private medical college, 3 surgeries happening here are less. So that leads to the issue of limited hands-on experience. To address this issue, I often host workshops and wet labs on a variety of topics such as paper multiplication, corneal suturing, SICS, regular suturing, lens loading and unloading. Balancing clinical duties with academic learning. In addition to the 3 lessons a week that I have set aside for my postgraduates, which include journal clubs, seminars and case presentations, we often hold academic meetings in our spare time to talk about a range of PG related subjects. Additionally, I push my postgraduate students to participate in state and national conferences, which has led to my PGs receiving award on a number of prestigious venues. To assist them in learning about numerous themes and the latest advancements in ophthalmology, regular CME on a variety of topics is also held. Redundancy from refraction. As the optometry branch is developing, along with the newest developments in optometry mechanics and equipments, PGs are frequently observed avoiding refraction. To address this issue, I have started dedicated refraction courses. Time constraints for research. In addition to their clinical practice and coursework, PG students also need to be well versed in the subject of research. To deal with this, the research department of our hospital trains the PGs to use e-library for research on various platforms, and I have regular meetings on thesis updates with my PG students. Student well-being and mental health. The demands of an increasing clinical workload and academic schedule make a healthy work environment crucial. To guarantee that I maintain a positive work environment, I make sure that I take my team on frequent department outings and joyfully celebrate all the festivals with full enthusiasm.
Dear students, respected teachers, and dear colleagues,
Dr. Ghosh.
Dr. Prashad Ghosh.
Thank you, madam. Thank you. We'll take it the questions at the end. Now I request Dr. Ghosh.
Faculty in West Bengal Medical Frequency Service. Welcome you all to this session of Teachers in Ophthalmology. I will talk for the next couple of minutes about the topic, Challenges of Postgraduate Teaching in Ophthalmology. I will subdivide my topic into 3 or 4 groups. And I will start with the biggest challenge. When a PG enters a residency in ophthalmology, he starts his dreaming about becoming a big phacosurgeon, not a big ophthalmologist. So that is the first challenge. So we have to impart them this knowledge that first they have to learn how to be a good clinical ophthalmologist, and their learning in surgical ophthalmology or phaco or cataract or whatever surgical line they choose, that will come automatically if they are sincere in their clinical learning. Nowadays, the next challenge is that the students are relying more on electronic or e-learning compared to the conventional teaching. They are more towards e-learning rather than reading the conventional textbooks. In our postgraduate days, some 25 years back, we used to rely mostly on the textbook teaching, along with the knowledge that are imparted by our teachers, mainly in the OPD and also in the OT. Nowadays, they are more relying on an electronic learning. Whether this is good or bad, time will tell us. The next point is that they are not interested in clinical research. They rather rely on the previously published publications for their thesis or dissertation. There is a big role for our medical teachers to tell them what is an importance of original research. We all know nowadays there is a term, publish or perish. You have to keep in mind lifelong that you have to publish your work, or else you will perish. Another important challenge is the challenge that regards the learning of soft skills. How to talk, how to communicate with the patients in the OPD, how to talk between ourselves in the OT in the time of distress, and how to explain a bad prognosis to the patient and patient party. That's a big challenge to teach them. They have to learn all those things very cautiously and effectively. Thank you.
Dr. Meena Devi. Thank you, sir. Thank you very much. Do we have Dr. Meena Devi? Dr. Meena Devi.
And Dr. Sriramchandramurthy Manchikandi from.
Do we have Dr. Sri Ramchandramurthy here? If not, then we'll move on to the last talk, Dr. Soni Sinha. So we have one question for each of the panelists, and then we'll end this session. So I want this one.
Rural posting can be made 2 years mandatory for them to get the degree.
So
Thank you very much for that.
So I want Ravindran sir to please say a few words after this talk about the well-being and the mental health.
Challenges and solutions.
Neeti madam to speak on the soft skills, and I want Vijaya madam to say about the clinical research, and I want Lahane sir, he can speak first and he has to go to the next session. So after this talk, you can just tell us about what madam showed is how these students are now going for the Google, for the surfing and all those things instead of looking in for the theory books, and then I request Jagatram sir to conclude with all the remaining things. Now we'll go with the last speaker of the day, Soni Sinha.
In this presentation, we'll be discussing the following headings. Regarding theory, the challenges are that the course is vast, there's no single book, there are difficulties in recent advances of paper 4,
And PGs come to us with an MCQ mindset and they have the thesis to do. The solutions that can be offered are some of the faculty can take classes, there can be more dialogue with the faculty, the faculty can point the PGs towards good online video-based learning resources, they can share good books and according to the chapters and good reviews. At the same time, they should emphasize the focus on fundamentals. Regarding diffraction skills, the challenges are that in most institutions, optometrists work on the diffraction, while PGs are reluctant to leave core clinical work. Here we can offer them formal mandatory refraction posting early on in the course, and the faculty can give advice and motivation regarding the requirement of this basic skill. According to clinical work, actually they find the clinical work overwhelming. 350 to 450 OPD patients with 3 to 5 GRs, 1 to 2 SRs and 2 consultants to look after, and an overwhelming amount of file work. Some of the solutions could be that it can be an academic day to emphasize learning, and they would have the clinical grand rounds preferably in the mornings when they are ready to go and not yet tired or engaged otherwise. And they would also love to have a shift work schedule. Regarding surgery, all the PGs have different learning curves. There are no outreach surgical camps occurring these days. They have to wait for PMG or free patients to try their hands on patients. Many institutes do not have wet labs or simulators. The solutions can be that emphasizing and establishing dry labs and wet labs, and if in the meantime the senior surgeon can supervise the PGs while they operate, anticipating the steps, helping and hand-holding them. These are some of my solutions that I have to offer. Thank you for your attention.
Thank you, madam. Just be seated and we'll quickly wrap it up in 3 to 4 minutes. Lahane sir, because he wants to leave. So, yes sir, your comments, and over the time, do you think that the attitude and everything has changed in the PGs?
I think first of all, presentation is very good. I appreciate both of you and all the teachers. Secondly, about the Google, about the AI and about the attitude of the students. See, we are the generation. We are the generation where we are fearful to our parents. It means we are fearing to our parents. Now, we are again fearful to our daughters and sons. The only generation. This generation is such a generation that both sides they are fearful. And so now what is to be done? So the parent, we are adjusted. But for the son and daughter, whatever they say, they want their Google, okay. They want AI, okay. They want not to read, okay. It is very difficult to tell them anything. If something goes wrong, they will say, yes, I don't want to live. What you are going to do? So it is, I think the patience of the student is very less, and in such situation, I think there should be some good solutions, good teachers, and I think the amalgamation of this, that will only solve the issue. Otherwise, it is very difficult because this generation gap is there, and in this generation gap, I think there should be a complete change in the education system, like what they want. Instead of we telling to the NMC, we should ask the student, आप क्या चाहते हो, and accordingly we should plan the NMC so that the problem will get.
Actually, my presentation was based on 100%. It was based on the feedback from my students. Okay, so that.
Fantastic. Yes, last comments from RDR sir regarding the mental health and the well-being of the postgraduates. Do you take any special care for that?
No, it's very important. No, right now these postgraduates needs a lot of hand-holding. So we have within the system at least one of our senior doctor will meet with them at least once in 2 months. Spend at least about 30 minutes, talk to them about their personal problems, not about ophthalmology. Just to understand what is their learning difficulties, what is their personal problems they are facing, because many of them are women either waiting to get married, there are a lot of challenges there, or they are married and there are a lot of challenges there.
So you have a PG grievance cell also.
No, so we have to understand their problems.
Yeah.
Again, then there are two groups of people, extroverts and introverts. Who are they? Today, a lot of them are introverts. You have to understand them from their perspective. They may not be contributing sometimes in the work, but you have to understand why they are not able to do it. If you don't understand why they are behaving in a certain way, then you cannot correct them or make them a productive ophthalmologist in the future. So this mental well-being, I was very happy about when Madam showed from Sandosh Hospital that she's taking care of. It's very, very important. If you don't do that, we may lose some of them. It's very, very important.
Thank you, sir. Vijaya Madam, about the clinical research.
One thing is that within I can talk about my college where I come from. Within 6 months of joining, they have to submit their thesis topic, which is compulsory. So before that, all the postgraduates get a research methodology workshop. So they do get, how you can do a research and statistics, everything is given. And after that, we know that ethical committee and CTR, and by the time thesis is given as a research topic, so they can publish, because as per NMC, it's compulsory to have a publication before you appear for the exam. And we do have every 3 months, we oversee how is their thesis work going on. But I cannot say that everybody meets the deadline. Many people lag behind. Very few they are very up to date. They do try to finish their everything on time. But I think having this research methodology workshop does help.
Fantastic. Thank you, Madam. Kirti Madam, I know if I give you a full day also on the soft skill, that it will be completed.
Just two things
so
on
only
soft
30
skills.
seconds, Madam.
Less than 30 seconds. Two things. One, we should be the role models because we had good role models and somewhere we have to audit ourselves for our students. Second, soft skills, I put a lot of focus on the non-verbal language. So we have to get trained in non-verbal language. It's a trainable thing. Empathy is a trainable thing. And we also have a research methodology workshop which is mandatory. And we've also added that this empathy module is mandatory for our PGs, which we do. And that's a trainable behavior, and non-verbal languages has to be really, really focused upon.
Are there any workshops or classes you take only on professionalism or for the soft skills for the
I
postgraduate?
take classes myself for my PGs on the soft skills each time, which includes the empathy, compassion. We just took a class for the undergraduates. We have a foundation course. In that we have this empathy and the compassion class, which fortunately or unfortunately I take every year.
Fantastic.
Promise for ARC to do 4 online PG classes.
Soft skill training. Fantastic. And she conducts a beautiful MBE courses. Wonderful classes are being done. Thank you, Madam. Thank you.
Thank you.
Last, I think, is the senior most faculty who has been retired as the coveted, the director of one of the famous institutes of India. Jagat Ram sir would like to wrap it up this please.
I can say that this program, AIOS-ARC, training the trainers, this is one of the excellent program, excellent initiative, and credit go to Dr. Prashant Kule and Dr. Srinivas Joshi. And I congratulate all the teachers and those who presented the video, those who are on the panel. And I don't want to repeat, but whatever problems are there, such as there is a inadequate number of faculty, there is a problem of teaching, practical teaching, surgical training, and so many other issues. I think we must continue this program and comes out with the solution. And I congratulate you once again. Thank you so much.
Thank you. Thank you, sir. Thank you. Request all the faculty, please come for a quick photograph. Speakers who are all there. I request the panelist and the co-winner of the next batch to please come over. I request North.
Okay. Thank you. Thank you so much.
Thank you, sir. Thank you for all your blessings.